to everyone that's joined to the Rural Behavioral Health Learning Community. This is Shannon Robshaw with the TA Network, and we appreciate everyone being so prompt to dial in this afternoon. So this month's presentation focuses on implementing wraparound and systems of care in rural communities. So as you can see, here's my contact information. Shannon Robshaw, there's my email and phone number. And Sarah Warner is the other lead contact for the Rural Behavioral Health Learning Community for the TA Network. You can reach either of us at any time to these email addresses or phone numbers, and we would love to hear feedback from you on whether you found this impactful and helpful, any other topic ideas that you would like for us to cover in future webinars. And I encourage you to get in touch with us. Also, by registering for this webinar and any of the other rural webinars, you're automatically joined to our listserv, where you will be forwarded the recording of this webinar and any other materials that we circulate through the learning community. And we also encourage you to use that listserv yourselves to communicate with each other and share materials or resources or questions. We usually meet every other month, and so the next time we are scheduled to get together will be the last Friday of the first week in March, which I believe is the 2nd. So we always like to kind of get a handle on who we're talking with when we have these webinars, so we kind of understand our audience and some of the things you may be dealing with. So we'd like to ask a couple of polling questions just to understand who all is on the line with us today. So we'll have 2 questions. The first one is, my organization can best be described as, and if you could please check the one that applies to you, we can get a sense of who all we're talking with. I think we'll give it a few more seconds to let people. Okay. And can we go back and see those results? I'm sorry, is it possible to do that? There we go. Okay, so we have private provider of services, we have lots of mental health agencies, child welfare, education, health agencies, and family organizations and other. Okay, mostly mental health agencies. Thank you, Tiara. Let's move to the next one. And so this is your role within your organization. So if you could please indicate your role. Executive leadership supervisors, family engagement lead, social marketing, family support provider, TA providers, okay, lots of family support. That's great. All right, do we think that's enough to, okay, good, great. Thank you, Tiara, for those polls. All right, so we're going to move right into the presentations at this point. And get the slide moving. So, yeah, here we go. I'm sorry. We're going to turn it right over to Erin Espinoza and Monica Rodriguez, both from Texas, and I'll let them talk about their roles there and also then just move right into their presentation. Thanks, Monica and Erin.
So, Monica, why don't you start with telling who you are while I bring up our slide we talked about, and then I'll talk a little bit about myself, and then we'll dive in. How does that sound, Monica?
Yeah, sounds great. So thanks for everyone attending the webinar today. My name is Monica Rodriguez, and I work in South Texas. I work with Tropical Texas Behavioral Health, which is a local mental health authority that services 3 counties. I always joke that people say, oh yeah, I'm from South Texas, and they say San Antonio, but in actuality there is something in existence 4 hours south of San Antonio. So that's the region that we serve, and we actually service a large border region, so that when Erin brings up the map, it's really clear that, yes, that's one of our catchment areas. I oversee yes waiver services within our agency and implementation of wraparound across all 3 counties as well. I've been with the agency a little over 9 years, and that's my role. I've been in implementation in this initiative for roughly about 6 years, so that's me in a nutshell.
Thanks, Monica. And I'm Erin Espinosa. I'm the director of the Texas Center of the Institute for Innovation and Implementation here in Texas, and we're a center of excellence that supports wraparound installation across the state of Texas, and have been kind of actively involved with Monica and her shop for quite a while. So what you should see on your screen right now is a map of our state, and I just wanted to kind of show not only how large we are, but also reference the fact that, you know, we have a bunch of different places that would be considered rural, and rural has a different definition kind of where you are. You know, people make the mistake to think that rural means small population, when in reality rural means you just don't have a really large urban center. So what you should see there is where you see the number 38, and it's the purple tip of the bottom part of the state. That's Monica's shop. That's the part of the state that she and her team supports. And I just want to bring your attention to that, because when they started this effort, they only had 2 or 3 facilitators. We're serving about 30, 40 kids. And Monica, you're at what, 220, something like that now, that you have currently?
We're at 220 families, and we have 20 facilitators supporting our 3 counties at this time.
So they literally grew this from the bootstraps up. Like, that's how it kind of came, and that's the story we wanted to talk about with you all today. And then I'm going to reference kind of the stuff that's going on across the state. So if you see there where number 34 is, another purple area, that's Houston. So right now, as of today, Tropical Texas Behavioral Health, there in the valley, in the tip of the state, serves more kids on a daily average population than the city of Houston. And there's a lot of reasons for that. But the part of the reason why I want to frame that is that Houston, you all should be familiar with, and the devastation of Harvey and everything else, is a very urban, we call it uber urban area. And so in order to grow a service and support array that's just as solid or as insignificant as Houston, you know, it takes a lot of effort to do, and Monica and her team did that. So I just wanted to frame that out for everyone so that you have a perspective of where Monica and her shop is and how it relates to the rest of the state. Thanks, Monica. So kind of digging right into the Texas story, we're working our state around really kind of cinching up what wraparound means, what it looks like, how do we operationalize it, what is the quantification of the effort. Really began back in the summer of 2011 when our Health and Human Services Commission, with some flexible dollars, tried to work together with our public health system to figure out what is it we're going to be doing in our state that we're calling wraparound. Up till that point, we really didn't have a model or a structure. We had a, you know, depending on where you were, you could be in Houston doing one thing one way, and Tropical or the Valley doing thing another way, or Dallas and doing it another way, and all calling it wraparound. So we convened a meeting and brought all the community mental health centers across the state together. So those numbers on that slide you saw a second ago, that's how many LMHAs, or local mental health authorities, support our state, 38. So we brought all 38 together and said, what do you guys think about us adopting a model? And we brought in the National Wraparound Implementation or Initiative down to actually talk about it. What we learned was that we weren't actually targeting the right population of kids initially, so we needed to target only the top 5% of the kids that had the kids and families that had the most acute needs. And we really needed to keep our staffing ratios down to 1 to 10. And then the consensus from the field was they just wanted one model with one set of fidelity standards, and so we adopted as a state the National Wraparound Implementation Centers model for implementation support, and that's the model that we rolled out. Now, as you guys can probably think on the phone, if you're in a rural community, that 1 to 10 thing is something everyone really struggles with, especially when you look at the fact that when we're in the rural area, we tend to be more of a jack of all trades and kind of having to do a little bit of everything because we're spread so thin. So I want to keep our eye on that marker as we tell our Texas story, and want to see that, you know, it can be done, but we also recognize the struggles around that. So then the state mandated that wraparound in that model and that format and that structure kind of be rolled out in the fall of 2012. So I'm going to toss it over to Monica, because Monica's going to walk you through what her agency was looking at that point in time. Monica?
So you all heard Erin mention that this caseload thing is not only a struggle, but it continued to be something that was unheard of because, like she said, you know, our staff that were doing direct service and completing direct service were used to these really big caseloads servicing lots of families, lots of kids across a huge catchment area. So our catchment area from one point to the next is roughly 135 miles. So you're talking about, you know, a catchment area that our staff are supposed to go in and deliver services to families across these 3 huge counties. So when this all kicked off, our leadership decided that, look, we're going to do this, and we're going to do it like the model is intended to do, because it seems to be whatever was happening prior to this implementation just wasn't meeting the needs of our families that really have these complex needs. So one of the biggest deals in this whole push was those caseloads. So our leadership said, no, we're going to stick to this 1 to 10, 1 to 12 caseload, and we're going to stick to making sure that our supervision and to care coordinator ratios is as the model is supposed to be. I was then moved over from one department to the other to just take the lead on this initiative. I actually had to go through an application process to get onboarded, to do some coaching. This meant that I was working closely with the state folks that were rolling this out. And this meant that I was going to get some additional training as far as I needed to go through this wraparound, this thing called Wraparound. I needed to get folded into this and how this was going to look on the ground. What was this going to mean to our agency? We needed to ensure that not only that we were following the recommendations of the NWI and the state. They were saying, you know, if you do these things, you know, put these things in place, put these things in place. But again, this was business. It just looked different. It looked different. It felt different. It sounded different. And so it all took a little bit to sit in and say, okay, so if this ratio, caseload ratio is going to change, then a couple other things have to change. We're going to have to look at what our expectations for our staff are. We're going to have to look at, okay, minimally, what are we going to put in place that makes sense? So as a team, I mean, it was a very small team. When we kicked this off, like Erin mentioned, there were 3 facilitators servicing, you know, a very large area. We're trying to figure out caseloads. We're trying to figure out population served. And so we focused on ensuring that we captured that family story. Our leadership bought into this and said, you know what, in order to really learn the model and learn how the process is supposed to be implemented, we're going to waive productivity for our care coordinators. We're going to allow them to grow skill and build their skill development around how the process is supposed to be folded out. And that was unheard of in our agency. Our agency has been, you know, everyone has productivity targets. Everyone has these monthly standards that they need to meet as far as direct service goes. And so this is huge. And so our leadership was right there saying, you know, this is what it's going to take to learn the process. We had some folks say, you know, if our staff are skilled enough to service families with these complex needs, then we need them to be doing it correctly. We need them to be doing it right. Something else that shifted and looked different, it sounded different, was what were the job descriptions of these care coordinators going to involve? We developed new job descriptions solely based on the model, the NWI model, and what it was going to take to implement wraparound in our community. Looking at the documentation expectations and saying not only are our job descriptions going to change, but how our staff are actually capturing these direct services is also going to look different. So that involved training, that involved lots of shadowing staff, lots of going out and actually teaching, different ways to ensure that you're capturing that documentation part of the process. Also identifying barriers. So people were used to practicing a certain way. They were used to case management as usual. They were used to, this is how it's supposed to be. And we had to go in there and really provide additional training to really shift that mentality of business as usual. This is treatment as usual. No, it's not. It's not treatment as usual. This is going to look different. It's going to be documented different. And so we have some barriers there because this is where you found out who was really in the position to really meet the needs and do care coordination to high quality. And then you figured out that it was because it was so different than regular case management, than traditional case management. That was our guideline. We were able to set some standards and some expectations around how this was going to look from day to day. So it took a lot of elbow grease in the very beginning because there was a lot of things that needed to be set in place to support an initiative that was going to grow so quickly. And I don't think that in the very beginning we anticipated it to really take off as quickly as it did. But as Erin shared earlier, we started with 3 facilitators servicing a very small number of families, practicing to the model, and now you're talking years later and we're at 220 families with 20 facilitators because the need was there. The need presented itself in our community, and we just were trying to run fast enough to meet that need.
So Monica,
go ahead.
Monica, real quick, I think it's critical here that we discover from you how and or why you felt it was important to create job descriptions that were different for wraparound care coordinators versus case managers. Can you tell us, what was that aha moment and, why it was so important?
So looking at traditional job descriptions in our agency really focused on ensuring that your monthly targets and your monthly minimums were met. It was driven by, these numbers on a monthly basis, and the actual job description was written so differently. When we figured out that it was going to look so different, the expectations for a care coordinator, it didn't make any sense that they would hold the same job description as a case manager. We really needed to set some accountability in place to really hold that care coordinator to really understanding that when you are implementing wraparound, it is not going to go out and do X, Y, Z, but it is that you're going to capture the family's strength, from a strengths perspective early on. You are going to really hold on to those core elements of wraparound, and you're going to practice them on a daily basis. And so the distinction between one job description that was a regular case manager, business as usual, this is what we're doing, this is how it's done, to what a care coordinator's job description held, it was just completely different. Again, going through and you can actually see the process in the job description. And that to me was exciting because that meant, okay, not only are we really looking at an accountability factor, but these are expectations that you can clearly set out and you can work with. It gave not only our leadership, but our staff and everybody in between a really clear understanding of what a care coordinator's job was going to be from this point forward. And it gave us a starting point to really say, okay, this is what it is, and this is how it needs to be practiced. And because our job descriptions, traditionally, again, they held everything, the targets just changed. And so when you looked at it from, a black and white perspective, you looked at, okay, we're going to track progress, but we're just going to track it in a different way. We're going to look at it at a different way. And so we were able to look at, quality measures based on whether or not this is actually being followed through or not.
Right. So for you all, it not only helped define the model, but because your wraparound care coordinators no longer had productivity, it also distinguished them as needing to be held accountable to the process orientation and to their job from a quality perspective instead of just quantity, right? And you had
Right.
you had families, because you are a rural center, so you literally had cousins that were working side by side, and felt like, hey, why am I being held accountable to these numbers and you guys aren't being held accountable to anything else? Like it was family, and you had to define the roles just like you would in a regular family. Like the eldest has a role, the middle has a role, right? I mean, did I
Right.
get that about right?
Right. And so again, because this was rolling out so quickly, that care coordinator position was also seen as like, wait a minute, something's different. Why all of a sudden they didn't have productivity? People were noticing not only within the agency, but that role, that wraparound facilitator or that care coordinator, again, just looked different. And so, yeah, it came along with some barriers, but overall, again, you spoke to that accountability factor, and for us, that was huge. It was monumental to really put it on paper and say, this is a way to really push things forward.
Yeah, and those of you on this call, I don't want you to think that productivity doesn't matter. It absolutely does, and we're going to get to that in a second. But I don't know that the productivity piece was the one that was so magical for you guys, Monica, or the expectations being set up clearly. But, ideally, hand in hand, creating space for staff to learn was important, but also holding them accountable to what the job description was equally important, and y'all just found a different way to do it initially. So I switched the slide.
I think both of them were both really important.
Yeah. Can you talk to the considerations for system of care and some of those things that you identified as this was growing?
Yeah, so when we rolled out the initiative with Wraparound and rolling out how that was going to look, at the same time we were trying to merge systems. And so in our community, Erin called us, we are a rural community. This means that we're working in colonias. We're working in areas that have a very small population as far as like maybe they have one school, and your elementary, middle school, and high school all go to that one school. And so in these areas, if there wasn't a lot of, you really don't have a lot of service delivery because one, the distance between one place and the other are very great. So access to services in general is a barrier. So we really needed to understand what our region needed. We really needed to understand in our communities where were the areas that maybe we're having bigger barriers with transportation or bigger barriers with really getting to those services, whether those services were mental health services, whether they be, health and human services, which maybe they needed social security services. And so we really needed to tap into coordinating regionally and looking at those chapters and those organizations that were already doing a lot of the work and folding them together. So looking at not only our faith community, looking at those churches that serve those rural areas, but doing a lot of groundwork and saying, how do I connect all of these dots? And that was one of the biggest challenges early on because in our community, there were so many hidden needs. So early on when we started implementing Wraparound and doing systems of care, I remember meeting with Erin's team and sitting down and having a community map, looking at, okay, how is everybody connected? We had some major institutes in our area. We had some psychiatric hospitals. We had DSPS had 2 main offices in our area. So how is it that we connected all those dots? We really wanted to look at those areas and looking at the barriers that could come up, which is, we work in a predominantly Hispanic community. So looking at the generational expectations, so servicing families in their homes made a huge difference. Families that had barriers to getting to the office. There was a lot of stigma around going to an office to get services. so that meant that I needed help. That meant something was wrong with me. We had to really tackle that barrier, that cultural barrier as well. We really were community-based. All of our services are done in the community. 95% of them are. So that meant that we removed that barrier of, oh, they have to come to our office. No, we're actually doing all of our work almost 100% of the time out in the community. That made a big difference in really breaking down those silos as well, because we were able to go to those agencies and say, you know what, we're going to have a meeting at someone's home, and it's really important that you be there, versus you need to come to the office or having a family come to the office. Also, we utilize technology to really address some of those challenges. In the implementation of Wraparound, I challenged our teams to be creative, really utilizing the technology that they have at hand. If you need to Skype in, if you need to conference in someone, if they have a team member that is out of state but they connect with on a daily basis, you can fold that person in on a monthly basis into your child and family team meeting. Our teams really bunkered down in this area because, you know, our staff members are really savvy. Some of them are really savvy with technology, and this is something that they identified with, and it's something that they practice. And so looping in all of these creative ways to fold in these really relevant and important people to these families made the difference. It showed the families that we were going to go above and beyond to ensure that they had those supports in place with or without us. And so that was a big deal in our community as well.
Did you have a chance, I got distracted with the dogs deciding to make noise all of a sudden. Did you get a chance, Monica, to touch on this Be Creative piece of it, like how you actually were growing service providers by engaging the community through your wraparound model?
Yeah, so when I went through and we really started looking at our provider base, a lot of folks didn't really know what it is that we were trying to build. A provider base, so we did a lot of legwork going. We went from, and I'm going to say the city because, and I'll give you a really good measurement here. I went from Sullivan City to Brownsville, and that's 130 miles of a stretch. And I probably stopped at, I don't know, maybe 35 barns because I knew that equine therapy was something that folks weren't practicing. I knew that it existed. I just needed to find out where it existed. And so we did a lot of legwork looking for folks that were licensed that could provide this service to kids who really needed that therapy. We did a lot of work at our school district looking at creating a memorandum of understanding with our district so that we were able to provide mental health services on campus, off campus, in the community. We were working with our teachers. We were working with our counselors. We were talking to our superintendents and really looking at educating and trying to spread that provider base beyond just a small, like our metro cities. You know, if it's just, one of our metros is McAllen, you know. McAllen is one of those big cities that has a lot of schools in it, and it's got a huge school district. But we wanted to make sure that not only McAllen had access, but all of the surrounding communities that weren't as big and didn't have those resources were able to really tap into this. And so that big creative piece was really important to us, making sure that this made sense in our community. And I know everyone's community is different, but in our community, that's how it needed to be set up because connecting those dots from the get-go was vital.
Yeah, I wanted to highlight that because, you know, going back to this slide we started with, all those purple centers that you guys see there, that's where Wraparound originally started as supported by our 1915 CRRES waiver. In 2015, the legislature actually mandated that waiver go statewide. So those words in purple were organizations that were getting support from INWIC. We're getting training and coaching support, and Tropical really kind of took the lead. There was no mandate for quality implementation. There still is no mandate for competency or fidelity. So it's up to the actual agency whether they participate in support or not. And what you'll see is that at that point in 2015, Monica and her team, they had been working for about 2 years on this. We're still only serving about 20 to 25 kids, only had 3 or 4 facilitators. And then the waiver went statewide. And so at that point, we were looking to serve 2,000 plus children and families in the wraparound care coordination model, and also simultaneously develop a provider array that could support the non-traditional services and supports that the waiver wanted to reimburse for, equine therapy being one. So the rural problems that we saw continued on, across the whole state. As you look into the part of the state in gray, that is West Texas. Like quite literally, you may have 5 people between you and the next 25, 30 miles. And so it's rural and vast. And yet some of the barriers that we were hearing were all the same. And so 2014 to 2016 is when the state buckled down and said, we're not only going to mandate that the wraparound model be used for our yes waiver kiddos, we are currently also saying it has to be done for LOC4. However, organizations, especially in rural Texas, were saying they didn't have the number of families that were needed to actually fill a full caseload. And even if they did, that the fee structure rate and everything else wasn't set up in such a way as to actually support the model. And at the same time, Tropical, Monica, you guys were going along thinking, oh, we've got this kind of figured out. We're getting coaching support. I'm out, Monica was out trying to do some supervision, but there wasn't any real standard practice around that just yet. It was kind of group supervision and growing that provider array because we were doing a lot at the same time. So what I wanted to point to real quickly was then we looked at what would it take if you're doing wraparound to high quality and high fidelity. What we found was you should be averaging around 65 to 70 face-to-face billable hours per month per facilitator. That was through some national work that the National Wraparound Initiative was doing. And so we put the dollars to donuts, and what we did is we found that a rural organization would be what we call here composite A. Typically a really small organization that only supported maybe 3 to 10 families a year. We found that the median number was around 6, so it wasn't quite a full caseload. And we looked to see if the fee structure actually would support that or not. And so what we saw, and what you'll see at the bottom of this slide, is that a composite A organization in our state could have been billing around $63,000 a year if they were doing high quality, high fidelity work with a caseload of only 6 kids. But they were only billing about $8,000. So we asked, what is it you're doing? With these high caseloads, you're actually causing yourself to lose revenue rather than gain it. And if you are trying to hold to the quality and fidelity of the model, you actually can support almost a full-time position and a little bit of supervisory time, even in the smallest organization in the state. So we use this projected fiscal chart to try to help organizations, no matter how big or small, manage their workforce and their workload capacity so that they could actually try to get to exclusive caseloads. We presented this information to Monica and her team there at Tropical, and the advisor staff got on board with saying we need to onboard more facilitators because if we build them on, we'll get more families and we can do more quality work. And so this next slide here is what productivity looked like for Tropical Texas Behavioral Health during that same time frame when we were trying to talk about how can you get to more quality effort with exclusive caseloads and managed time. Monica, you remember that? So this is the period 2013 through 2014?
Yeah, so I got, this is where I started, having those conversations of, wait a minute, it's really not looking the way it needs to look. There's something missing. Like Erin mentioned, we were doing group supervision, but it wasn't anything that was set in stone. We were tracking along thinking, okay, this is okay, but, something's missing.
And so what you can see here is that on a monthly average, they were only getting about 20 hours face-to-face with families, even though they had exclusive caseloads, and even though they didn't have productivity standards in place. So what was going on is this takeaway that Monica came up with. Do you remember this, Monica?
Yeah, so there was this big aha moment, and it was in order for me to know what was going on the ground, I really needed to understand what they were doing and what they needed to do before holding them accountable. And so I needed to go see in the community, meeting with my staff, what it is that they're doing and what it is that they're not. And so this was huge. something that was, again, I use an aha moment because it was something that I'll always remember saying, okay, if I can't do this, I can't expect them to do it. If I can't demonstrate it, then, if I can't hold them accountable to it, I need to really, really get down to the nitty-gritty and understand what.
Go ahead, Monica.
So looking at.
So here's where we were then. So as Monica got out in the field to try to really figure out what was going on, she felt like, and her team felt like, that they had actually figured out supervision in a group model. They were really going fast and building a provider array, but they weren't doing individual support. They hadn't quite figured out all the nuances of what does Fidelity Wraparound look like. And so we did a study with them using WrapStar through the National Wraparound Implementation Center. And now in hindsight, I think we could have done this another way. However, that was the element we had at the time. And no surprise to us at this point, we saw that they hadn't had any turnover in staff. The data management was pretty spot on. They did include job descriptions for staff, so there was a performance assessment in place. They definitely had a good morale, they had good coaching, group coaching models in place, and they had some influence on the systems. But this was the thing that
we thought we were doing great.
Yeah, and I don't know where the slide went, but when they got their Fidelity Score, and I gave them their findings over the phone, and they're really excited about that first slide. Well, your Fidelity Score, I don't need a slide for it, Monica. What was your Fidelity Score?
So our Fidelity Score was 45%.
Yeah. So they were like, oh, no, we're safe. Yeah. What did we do?
You heard crickets in the room. Our leadership was like, you just saw it on their faces. They were like, we are A students, and you gave us a 45%. I mean, and all of our executives were in the room, all of our leadership, everybody was there when this big unveiling happened, 45% to Fidelity. So we call it the Fidelity fail. And
and it was important, and I say this because Tropical was really moving along and doing a lot of stuff in rural Texas that we were all impressed with and everybody felt really good about. But the reality was, just because it felt good didn't mean it was perfect. So the Fidelity was at a 45%. The other thing that we don't have here was the fact that their outcomes weren't looking that good. So we didn't have a lot of families making it through transition, right? They were going in and out of hospitals, right, Monica? And y'all were like, wait a minute, this isn't okay. So we feel good about this, but we're not getting the outcomes we want. And we're not getting the outcomes we want because we're not doing it to Fidelity. And so they had to come to the terms with, we got to use the data to tell us we need to adjust. And so what is it we need to do? So Monica, can you talk about what y'all did the next 90 days?
Yeah. So quickly, we had that moment of total failure, and then we looked at, okay, so we really need to hone in on what a job description for the manager looks like, my job description, my supervisor's job description, looking at the duties assigned to the manager, looking at the duties assigned to the supervisor. We immediately said, okay, supervision isn't structured, supervision isn't in place the way it needs to be. So frequency and duration of supervision was critical to our program and to really ensuring that our program was going to improve that Fidelity Score. We looked at revisiting expectations for wraparound facilitators and care coordinators. We looked at the staffing ratios for supervisor to care coordinators. We needed them to stay at a strict 1 to 7. And so we really started analyzing the data that was being gathered across the months that we were practicing so that we could really look at, okay, we know that 45% isn't where we need to be. How do we move from here?
And this is what happened. So they didn't put productivity in place yet, but just because they doubled down on becoming more specific on their process-oriented supervision, doubled down on using the data to inform when to assign new cases to onboarding new case managers or care coordinators, looked at their fiscal mapping to start hiring correct staff and getting the right supervision structures in place, literally in 90 days. What you can see on this chart here is they doubled their productivity. So the average productivity moved from 20 to 25 hours a month to 53 without any other expectations changing. Right, Monica?
Yes, so these numbers seem to, again, they doubled up because all we simply did was frequency and duration of supervisors. We started tightening up those processes. Again, our numbers doubled, and they continued to increase the closer we got to really doing high fidelity, high quality practices.
And here's the takeaways. Tell us about that.
So my supervisors, in meeting with their staff regularly, they became more comfortable in the model, which allowed them to really be able to turn around and grow skill in their staff members. When staff were meeting with their supervisors on a regular basis and building skill, their confidence went up. You saw that, quality practices improved overall. And the takeaway from here was that once you really beefed up that piece and you looked at improving your quality, all of a sudden your productivity shot up. Because this was important to our leadership. They wanted to know that this program was, it wasn't a program that could stay at productivity at zero. We needed to know that this was moving, and just really looking at those structures and redoing that and taking a look at that bigger picture allowed us to take away that, one will equal the other.
And so just as critically, you guys also recognize that more doesn't always mean better. So when you saw people, doing too much face-to-face time, you learned that what that actually meant that wraparound wasn't happening there either, that they were falling into case management as usual or turning into skills trainers, right?
Right.
And that you needed to actually have a unit described as a specialized wraparound unit. So you needed a job description as a manager. Like, what did it mean to be responsible for supporting 4 supervisors across 21 facilitators, and how that had to be defined for you within your organization so that you weren't getting pulled into other projects and other things like system of care or trauma-focused CBT or any new thing that the organization took on, like, because you're a doer, they want you to do, and you had to do what you were doing well and not do everything. Right, Monica?
Right. Yep,
So
that was a big aha moment as well.
Tell us a little bit about that, because I was sitting in your office when your boss said, it's your job. Remember? Yeah.
So I remember I said, we have passionate leadership, and leadership is passionate about ensuring program development goes well. And so they basically said you need to really focus on building quality within the program, and that's going to be your primary job. Again, that is focusing on what your supervisors are doing with your staff, looking at how they're implementing the model. Are they having their weekly supervision? What does that look like? That meant that we needed to go back and look at those non-negotiables around quality. We didn't want more services. We wanted quality services. So if somebody was pushing out 80 hours per month, we knew that that wasn't high-quality wraparound. We knew that they were throwing in other things. They were providing direct service, of something else. And so whatever it was that they were doing, it wasn't wraparound. It maybe was regular case management or, something else. But the direct link to productivity and fidelity practices, this was so clear. It could not be clearer. Our data supported it. Our monthly report supported it. We looked back and said, look, if quality improves, then we know that our productivity will follow.
So that's it. That's all for our part of the chat. I think we can turn it back over to you, Shannon.
Great. Thank you so much, Monica and Erin. We can take a few questions now. We're going to try to carve time out at the end of the webinar for additional questions. But if anyone has a question, you can type it in the chat box, and we can see if there's anything we want to try to address right now before we move into the Louisiana presentation. Anybody have any questions? That was really very informative, and I thought extremely, operational and practical information that that I, in my role with the TA network, see a lot of sites struggle with those very operational type questions about implementing the model to fidelity, and in hearing just your strong management approach, Monica, is really what struck me about your strategies there, and I've I think a lot of sites could benefit from adopting some of those same practices.
Thank you so much.
Yeah. So I see Carrie's typing. Let's see if she has a question, and then we'll, well, I don't know. I don't see anybody typing. Okay, here we go. So Carrie's question is, what was the cost to attend the NWI training and the RapStar TA to obtain your Fidelity Score?
Well, I will take a stab at that. So the state in Texas, the state meaning the yes waiver, actually invested in that for the entire state. So there was no cost to the LMHAs to participate in training. That was a part of, and still is an ongoing part of our workforce development plan. So what you heard Monica talk about a minute ago is that she actually applied to become a coach candidate and is a current coach candidate with us here now to become an NWIC certified coach. So our plan in Texas is to have a cadre of certified coaches that are housed both at the Texas Center as well as within local organizations who actually can replicate the model ongoing, actually no cost to the state. So to answer your question is, if you were interested in going that way and going that model, you would have to reach directly out to NWIC, and they could get you a proposal together, Carrie, to tell you what it would cost to do that kind of work with you. What I'll say about RapStar is it was extremely helpful, but you may want to talk to Monica more offline about how much work it was for her and her team to do. There may be other ways to use administrative data and things that you have on hand already to kind of help you improve your Fidelity work in addition to something like RapStar. They don't recommend RapStar as a baseline. It's really something you should do around a year or two after implementation to kind of tweak your system. That's why we didn't do it with Monica until after 2 years, right, Monica? It was like 2016 when we did it.
Yeah, you have to. Yep, it was just under 2 years. So you really have to sit in the model for a little while because it allows you to realign where you need to be. It helps you correct yourself.
Absolutely, and it's designed for that, so it is a good tool for that kind of stuff. So, Carrie, I guess the long answer is there was no cost to anyone in our state because the state invested in a contract with NWIC to provide workforce development support.
Thanks, Erin and Monica, for that clarification. You know, that's just a whole other continuing conversation about where does that, if you're going to pay someone to come in and train, you know, someone does have to pay for that, and if it's not you or it's a state, or, you know, how to find those resources and how much that really is, how much of an investment that's going to require. So we can, again, I would urge you to reach out directly to NWI or NWIC and have those conversations with them about that if you're interested in that. So I see one more question in Sarah Kleber Lowry, and then this will be the last question before we move to the next presentation. But in rural areas in Indiana, we are running into the barrier of having people that meet the criteria to become a wraparound facilitator. Any suggestion on how to address that workforce issue?
Monica, I'm going to let you take this on. Tell them how you grew and actually ungrew. You had to get rid of a couple too, right? So tell us about your work.
I love how you highlight undid something. No, we actually worked, that job description is actually going to be really important in creating that criteria. Also, we partnered up with our local universities. We partnered up with the social work department and the rehab and counseling department. A lot of folks knew about our center, but they didn't know what was specific to the wraparound facilitator position. We actually also recreated the questions, the interview questions, and what it looks like to onboard in the very beginning, so you were very clear as to whether or not they had the characteristics, the value base, and the criteria to really do that work with your families. That was something that we looked at in the very beginning as well. I hope that was helpful. By criteria, if you mean our folks don't carry license, they aren't licensed, so they're QMHP CS. I don't know if that is helpful at all.
Yes, just to add to that, yeah, so the state criteria didn't have any prohibitions other than the fact they had to be bachelor's level folks. So that might be kind of what's happening.
So I
maybe,
see Sarah.
maybe she's clarifying. Yeah, looks like Sarah's clarifying.
Yeah, and I know Indiana is an INWIC state and is having training and coaching from INWIC, and so it could be the issue of the RAP facilitators not meeting the standards for, you know, that INWIC has helped develop for the RAP facilitators as part of the overall coaching and training process. She said that would be the difference we are encountering. There is a requirement to have had 2 years of supervised SE. Okay, I see. So Sarah, I would suggest we can continue to try to provide you some technical assistance. Either I'm actually the coach with Indiana. This is Shannon, so I can continue this conversation with you offline or encourage you. That's why we have Monica and Aaron's emails on the slide there, so you can reach out to them directly following the presentation. But thank you for those questions.
Thank you, Sarah.
So thank y'all, Aaron and Monica, for that. And we'll continue. I mean, this is sure. These webinars are certainly not the ultimate answer to anything, but we want to encourage you to think about some of the successes from other communities, and then just continue those conversations and those learnings as you continue your work. So the next section is Sarah Strader and I are going to talk about our work in Louisiana. As most of you know, this is Shannon Robshaw. I'm currently with the TA network. But prior to that, I worked in a couple of different states in South Carolina, and prior to that in Louisiana, and was the lead staff for the large-scale system of care implementation there. And Sarah worked in one of the very rural northeast Louisiana regions in that initial implementation. So we're going to talk about our experiences during that time, my view from sort of the state level development work, and then Sarah's view on the ground trying to make it really stand up and work. So so Louisiana, again, we started with some pretty significant goals, and this was, you know, straight from the governor's office across the leading department executives, which I'll show in a minute. But the goals were to reduce the number of children in youth and residential settings, to reduce the state's cost of providing services by leveraging Medicaid and other funding sources. So that doesn't mean reducing the amount of dollars spent on services. It means being smarter and using state dollars to bring in additional Medicaid dollars, so we can actually grow the overall amount of dollars spent, and then improving the overall outcomes for children and their families. And as I mentioned, this is a very broad scale, very highly supported effort, a leadership team from the governor's office, child welfare, Department of Health and Hospitals, which included Office of Behavioral Health, as well as developmental disabilities, public health, juvenile justice, and Department of Education with family members, led the whole process. We had a large, very broad planning group from each of the agencies and key private stakeholders, private providers and advocates and other stakeholders to help us develop the system design. We had multiple work groups put together. We did a very broad, we contracted out for a very detailed financial analysis to understand what dollars were being spent where, on what services, and whether they were evidence-based practices, and whether they were could be leveraged through Medicaid. So very, very complex fiscal analysis to determine what dollars could be shifted and used more effectively. We had parent and stakeholder participation, across, up and down the whole level, with external stakeholders and parents making up 40% of all of those different work groups, system design work groups. And we contracted with national experts. Again, we had an actuarial firm contracted to do the fiscal analysis. We had system of care contracts. Again, that was for the TA network. That was when we contracted with the University of Maryland Innovations Institute for system of care consulting, and Sheila Pyries with the Human Services Collaborative, and TriWest. And so we the state was clearly very committed to this and put a lot of resources into planning the implementation. We had a multi-departmental governance structure. Again, all of that leadership team at a certain point was converted from an informal leadership team through an executive order to a formal governance structure by executive order from the governor at the time. And they had to, they were responsible for the ongoing implementation and planning of the large-scale system of care. They could make decisions around financing. They were the agency heads that once we got the fiscal analysis and knew how money could be moved around to better leverage, they could make the decisions on to actually make those funding shifts happen. The implementing agency was the Office of Behavioral Health within the Department of Health and Hospitals. So the governance structure, governance body oversaw the functioning of the Office of Behavioral Health and the various contracts they were responsible for establishing. They, did policy, monitored adherence, looked at, we had an outcomes committee that identified what outcomes would be tracking, and they monitored those outcomes, and then had memorandums of understanding between the Office of Behavioral Health with the governance body and between Medicaid and other agencies, just laying out the operational relationships and roles and responsibilities of the various agencies. So the Office of Behavioral Health, again, implementing, not governance, kind of running the trains, managing the overall, operational process, executing the contracts for a statewide management organization and other contractors that we needed to come in and build out the system of care. Contract and memorandum of understanding with the state Medicaid agency, which was also within Department of Health and Hospitals, but they were not the same agency, and Medicaid has to be the single state authority, so there had to be an MOU around, how OBH would work with the single state agency for Medicaid to make sure that those rules and the federal requirements were followed appropriately. And then they also coordinated training and technical assistance for the implementation on the ground, and of course just reported into the governance body. So that was so the system design. I don't think I have a picture of the system design in here, but what all that ended up through the planning process, that very broad-based planning process that I discussed, and through the implementation plan is on the ground. It intended to look like there would be new provider organizations that would be exclusively organizations that exclusively provided wraparound care coordination, no other types of services, and they would be contracted through the statewide management organization, which was contracted by Office of Behavioral Health. We also were standing up brand new family support organizations in each of the implementing regions. We also had one of the big issues in Louisiana at that time was that we had, and because Louisiana is very rural, not surprisingly, we had a very limited array provider network and limited array of services. And one of the things that we were also transitioning to is, as we were shifting things to be more Medicaid funded, the providers needed to learn how to bill Medicaid and not just have one-off contracts with some of these other agencies. So there was a lot of work going into developing the provider network and bringing the providers up to be able to be Medicaid providers. And then we also wanted to build the natural supports network. So that was sort of all system design in the plan, but now it was like, how are we going to actually really try to make this happen on the local level? And we spent a lot of time trying to think about how we could really set the locals up for success. And so we made the decision that what we wanted to do was not. And we also we had 10 geographic regions in Louisiana, and it was going to be the system of care was not. We did a waiver, different waiver than Texas, but it was a similar process. So it was definitely a statewide implementation. There was no question. We were going statewide, but we were going to do a phased-in approach, phase 1 and phase 2. And so we wanted to start phase one with the regions that we felt like would be most successful to increase buy-in and just to build some momentum for the statewide implementation. And so we opted to go with a request for applications. We did not end up, the state could have said, okay, we're going to charge, the community mental health centers in lead in each one of the 10 regions to take this on and make it happen. But we decided to go a different route and tried to set up a process by which we could gauge the level of readiness in each of the regions, the willingness, the interest, the level of commitment by the wide variety of stakeholders that would need to be in place to be successful. And so we decided to do a request for application process. And we wanted to know, who was most ready and most prepared to be successful. And each one would then, so we used the 10 geographic regions of the state, and each of the implementing regions would support one family support organization and one wraparound agency, as I had mentioned before. And the tenor of the application was not, again, it wasn't to try to identify a lead agency that would be in charge of it all, or who the wraparound agency was that would be in charge of it all. It was really trying to gauge the level of collaboration in place, the value the region placed on the collaboration. Did they have the right people at the table? So we asked questions about, were the juvenile judges involved? Was the local school board involved? The schools? Just who were parents and youth involved? And so we really were trying to get a handle of who was at the table and who was committing to work together as a region in this in that region. I apologize for my bulldog barking in the back. Hopefully he's leaving. So the request for applications, here's some of the more things. We based it off of the NWI readiness assessment, but we modified it a fair amount to get at some of the specific things that we wanted to make sure we're going to be in place for those initial regions. We gave a fair amount of background to the whole process the state had gone through, the decisions that were made, who was involved, and then questions, these sort of readiness questions. The other thing we did, even in advance of the request for applications, there was a lot of communication with stakeholders through the whole planning and system design process. That we had public meetings monthly. We had electronic newsletters. We had a website where we posted information, and we also did a series of town hall meetings once we kind of got to the point where we knew what the system design was going to be and what our process was going to be for selecting the initial implementing region. So there was just a lot of communication coming out from the state offices, and again, having those providers and stakeholders and family members being so involved in the actual planning process. We just really tried everything we could to help people be current on what the thinking was and try to generate buy-in through that whole process. So some of the other things we did trying to support success on the ground is, so here's the timeline. So we again, trying to promote collaboration and not necessarily competing applications from a given region. So we had a process set up by which people could sort of announce that they were interested in participating in that in a particular region, and then so those people that were interested had a common place to contact each other. So we had a list of regional points of contact that wanted to participate in that, and we posted that to the website. We had a running list of questions that we would answer every week, just general questions that, could talk about system of care in general, or the RFA process, or just any number of different things, financing. So we kept a running list of questions up constantly. We had the application deadline, and we had them come in and actually present on their application, not just do it in writing. And then we announced the awards, and the goal was to, so you see it's a pretty ambitious timeline. One of the things we did during the RFA process was, again, to provide as much technical assistance and support in education as we could. We announced the process, with a state level kickoff meeting, and I think we had Michelle Zabel come down and with the TA network now, was with the Innovations Institute only at the time. And so we had some of those, high-profile national consultants come down. We always made a point of having high-level leadership from all the different state agencies participate in these types of stakeholder meetings. So we had a kickoff meeting to describe the process, take questions. We had weekly webinars, which I'm going to show you in a minute, to try to help them through the RFA process. And then again, questions, that ongoing sort of question and answers list on the website. So we did a series of webinars. There were weekly webinars during the time before, when we let the application, between the time we let the application and when it was due, on things that we felt like would be helpful to the regions to be educated on. And so we had, all of these different webinars. You can see very much focused on system of care orientation, roles of family organizations, the role of wraparound, and then also very practical things like how does that work with a new statewide management organization. This was also the same process by which Louisiana first brought Medicaid managed care into the state, so all of this was brand new. So there was a lot of information about that. We had the National Wraparound Initiative come in, doing a presentation about wraparound. Again, we had a whole lot to do to support our providers as they move towards becoming a Medicaid provider versus just a contracted provider with the state agency. We did not have wraparound in the state. We did not have peer support, and so we needed to explain the roles of those two organizations and the services that they provide. And then just general system of care training. So this was, these were webinars that we would host with folks, some of our experts calling in from wherever they were all over the country, also hosted by high-level leadership within the various child-serving departments. We went through the process. We identified the first cohort of regions that we selected through that process. And then we wanted to try to think of, again, this was viewed as, this whole process was viewed not as a competition or like a contracting or an RFP, healthy competition sort of thing. We really wanted to invest. We wanted to view this as a state and local partnership and invest in those local regions and in those new organizations we were trying to stand up so they would be high quality and have the best chance for success. It wasn't trying to see, what we could sort of get through the competitive bidding process. It was really how do we make the best choices of where to start and what are the investments that need to be made to help try to create as much success as we can. And so we had startup funds set aside for all, because they were brand new agencies. There were startup funds set aside for that so they could begin their staffing and training process. We had actually staff move from the various other child-serving agencies, state-level agencies, into the Office of Behavioral Health for a period of time and changed. Their positions didn't move. They were still, their positions, their FTEs were still in their home agencies, but they physically relocated over to Office of Behavioral Health to create this cross-system implementation support team, because it really was intended to be serving all these cross-agency kids, and not everybody, there weren't enough people to help support the regions as they began implementing for technical assistance, and there needed to be some education and training about what those different agencies' expectations were, how they worked, what, just some basic education about working with those agencies. So we had that. That's what the agency-specific foundational training, so you kind of understand that. We had system of care training and education plan for each region. these were all kind of managed by that cross-system implementation support team. We had each region was required to work with that cross-system implementation. They had their own consultant to develop a region-specific technical assistance plan so that we could, because 10 different regions in Louisiana are 10 different regions, and so we really had to tailor those TA plans. And there was, intention of ongoing implementation support. I mean, the state of Louisiana also did like Texas and contracted with the National Wraparound and, Time Innovations Institute for wraparound coaching and training and other types of implementation support around, working with Medicaid, contracting with the state management organization, just various types of practical operational things. So I'm going to turn it over to Sarah. All of that to say, the state was very intentional and deliberate and invested a lot of resource trying to make this successful, engaged. We had the practice that we let any stakeholder that wanted to participate in our system design work groups participate. We didn't tell anyone they couldn't participate. So we had a lot of people participating, a lot of resource, a lot of high-level commitment, and so it was very intensive and very broad and very complex. But it still was just, and I sort of exited the state, moved to South Carolina pretty quickly after this first round. The cohort was chosen. Sarah was there. She's going to talk about it, but it's just watching. Even with all of that investment and all of that, forethought, it still seemed to be a very, hard lift to get things up and going, and really holding to the values of system of care and maintaining fidelity to the wraparound practice. But Sarah's with an agency that was one of the best in Louisiana, is one of the best in Louisiana still, and was there from the very beginning through this whole process. And so now she's going to kind of tell you about what the reality was on the ground as a result of all this.
Thanks, Shannon. Yeah, so we were a local nonprofit startup, and so there were 6 of us that left an agency to be able to start this wraparound agency when the state moved. And so we applied. We got it for the Northeast region. And if you don't know anything about the Northeast region of Louisiana, it has 2 of the top 20 poorest parishes in the nation. And so the area we were serving was extremely rural. In one direction, our farthest client or youth and family that we served would have been an hour and 45 minutes one way. And so when you really think about rural startups, there is a lot that comes with it. And so we really had no history of wraparound. We didn't actually know what it was. And so January 1st, when it went live in Louisiana, we had no idea what we were doing. And but the good thing about that is we got to really set a stage of what we wanted our policies and procedures to be. We were able to really create the value system of our organization and what we wanted to obtain, like those objectives that we knew were important of keeping kids out of long-term care and really keeping them in their home and in their community. We were able to really, base everything we did off. We were going to do whatever it takes to make sure we made our community better. Now, when we started, we had the idea that we were going to be this small agency. The slot allotment in Louisiana was 240 for each region, so 240 youth that we could serve in each region, which would be that we had a 1-to-10 ratio as well, similar to Texas, and so we were going to hire 24 facilitators. And so our mission when we started, before families were coming into care, were hiring quality staff that would join us in this mission. Now, we'll tell you, is as much prep as Louisiana state leaders did. We started January 1, and we didn't get any of those startup funds for the first 2.5, almost 3 months. It took that long to get our contract in place. And so for those executive leaders on the phone, imagine starting a business where you're not going to have families and youth come into care until March, but you have to build up and start paying people to come on board and hiring facilitators, and you have no funds to do it, because we were the only agency of the 5 initial phase 1 that did not have a parent company. And so you can imagine the stress that put on us as an executive leadership team of trying to figure out, okay, how are we going to make this work? We knew some of because of all the prep meetings that Louisiana had, we knew of some of the expectations, as Shannon spoke about, but we really didn't know enough at that time to know all the intricate details that it was going to take to offer high quality and high fidelity wraparound. And so we made a commitment. We were going to under-promise and over-deliver. And so in Louisiana, there had been multiple therapeutic services or different groups or all throughout at every level of the state that really would say one thing but then live out another. They would make a commitment to come see a family, but in the end, if a family was an hour and a half away, you may have a worker just not show up. Or if they did show up, they may not come back if the family wasn't where they were supposed to be, which in Louisiana, the rural population, you may have one address, but it's not really the address of the family you're trying to see. It's just the only address they have to give you. And so you spend time tracking down people. And so we knew that from the very beginning, if we did anything well, it was going to be that we're going to do what we say we're going to do, and we're going to do whatever it takes. And so when we started researching like the wraparound process and, the principles of wraparound and what it involved, we hung and clung to that persistence and unconditional care, right? And so we were really trying to whatever we did, whoever we hired, if they could buy into that value system, then we believed we could figure this out. And so we had care management, and we had what we knew of the wraparound process. Now, thankfully, the state of Louisiana contracted with the Institute for Innovations early on, and so what we knew about wraparound was being delivered to us through that lens. So that was very beneficial of the training and the coaching. And so I was able to participate from the beginning of learning just how coaching really needed to look and how training really needed to look from that NWI, Institute for Innovations, INWIC, all of that, their mindset. And so that was really beneficial as we started up and trying to deliver this process and model that you could have success as long as you were able to implement it a certain way. And so early on, we bought into that. As an executive leadership team, we tried to do everything we could to balance what our facilitators saw as care management. And so we would try and be the barrier for them when we talked to them about things or when we implemented things, that they could focus on that wrap process and that they wouldn't get into the care management side that really pulled them away from implementing the wraparound process. And so there were many things we had to do because we were so new. It was new to all of the state of Louisiana, as well as it was new to our community. And so we had to meet with the community members face to face. We had to let them see that we were people who were committed to following this through. We would do little things like teach staff how if you create a meeting time, you keep the meeting time, you show up early, you follow up. Those things sound basic, right? They sound like, oh, everybody knows these things. But with the type of community we were serving, it was absolutely necessary that you didn't show up late to a meeting. It was absolutely necessary that you as a facilitator, you were not one to cancel a meeting. It was necessary for us as a leadership team to get out and go have meetings, meeting with OJJ officers, meeting with DCFS, because people felt like we were competing with them early on in those early years in 2012. They really thought we were going to take away their jobs. and we had to do everything necessary to show that this was a true collaboration, that we were put in place to try and create a more sustainable community, to try and create more sustainable resources, so that we could all be successful as long as we could get all on the same page. And so, you know, the other thing we did was we tried to make sure we were hiring people that were of that same value system. You know, as we learned about wraparound principles, as we knew what we wanted as an agency of just people of integrity, people of respect, people that were willing to serve, whether it was in the best benefit for them personally, but they were willing to serve because it benefited someone else, that we knew if we could hire for values, then we could teach skill. We could train skill all day long as we learned it, because early on we weren't sure what we were really needing to make a quality facilitator and a quality wraparound team. And so we're very strategic in who we hired and how we hired. The other thing is when Louisiana started, the budgets they suggested worked off of like a 98% capacity. Like you had to be 98% full in your capacity to be able to make your budget work. And we just knew from in-home work that we had done in the past that that was probably an unlikely percentage. And so we really needed to budget and be fiscally responsible in the sense of how we set up our structure in our organization. And so for the first 6 to 8 months, our executive leadership team did a lot of administrative staff type of things. We waited to hire those positions to see what we really needed. We budgeted off of right around a 90 to 92% full capacity, knowing that we would have to build up to that as well. And so we waited 6 to 8 months, and then we decided, you know what, we really need a separate assessor. We really need someone focused on bringing in and notifying families and being able to respond. So because with the SMO in place, and because Louisiana was just doing so much change at one time, which is very noble, the way it ended up on the ground is our wraparound agency, we were responsible for bringing in families, for notifying the community, and for making sure they knew who we were to have youth and families come into service. And so we ended up hiring a part-time intake coordinator, as well as a part-time community resource specialist. And so we did that because it was necessary in those first few years to have people very dedicated to finding the youth that needed to be in service, finding the right youth. As Aaron said, in Texas, they had to determine that. The same thing happened in Louisiana, where we have to find the right youth that need wraparound and that would qualify for these types of services. So we had to make some administrative costs that were not originally in the plan, but doing that ended up benefiting us to have our facilitators focused on quality care and high fidelity wrap. And so, and in that, it also allowed us to have high staff retention because we were able to pour into our facilitators and pour in to their growth and their skill utilizing the INWIC tools. For them to be able to go out, and when they were in a home with a youth and a family, they could fully focus on trying to implement the process. The other thing of just practical pieces of boots on the ground is we just really tried to empower facilitators. Because of the rural nature, we had to make a decision like we're willing to pay mileage. So that there's no, luckily we were a PMPM state, and so that really helped us in setting up how, just a structure and just some, fiscal decisions that needed to be made. And so we were able to pay mileage so they did not fill that pool. We were able to set up in our policies and procedures certain things within our flexible schedule that really allowed them to meet the needs of a family, whatever that was. And then we were able early on to regionalize staff. Because we had such a large area to cover, we wanted to make sure that we gave them the best opportunity to be successful in implementing the process. And if we could regionalize staff, then they knew how to build the service array because that was also ended up on the wraparound agencies as we started rolling out. And so the other thing we set up just in general is really understanding that because we started as a local nonprofit, because we weren't a parent company, we had to come together as an agency and realize that there was no, this is not my job. Everything we did set the stage for success, not just in how we delivered care to families, but also how we as leadership delivered care to our staff. And so we tried to be examples when they were in the office of how connecting with people, doing what you say you're going to do, implementing the WRAP process by, not talking about a colleague without a colleague, similar to not talking about a family without a family, like living out the little pieces of the principle to show what this should look like out in the community. And so obviously there's a lot more that could be said, but we're kind of running out of time, and I want to make sure we leave a few minutes for questions. But that's the gist of just some pieces of what it takes to really be effective in the rural communities implementing this process.
Thank you, Sarah. And I wanted to get a clarification. Early when you started talking, you said you tried to kind of buffer the care management function away from the wraparound facilitation from your facilitators. Do you mean by care management, do you mean dealing like some of those the statewide management network requirements and those sorts of more administrative bureaucratic things?
Absolutely, because the state knew of one way to do it, and they were making all of these changes. We were still kind of fighting this managed care side, which is very similar. You tend to go with what you know, and so care management and how to case management, and so we were having to kind of buffer that from what the requirements of the SMO or the state were, and try and keep our facilitators focused on high fidelity, high quality wraparound, and not get pulled into that, the case management side. Yep.
Yeah. Okay. All right. I thought that's what you meant. Thank you for clarifying. So we have just 3 minutes. Do we want to take? Is there a quick question anyone has for Sarah, or anything about Louisiana, or anything else about Texas? Remember that you have all of our email addresses if you want to contact any of us directly. And we're asking, I think we're trying to start a survey process. Thank you, Sarah, for that. That was very helpful. I appreciate it. It's interesting to hear that perspective. So the Institute, we're starting to try to do some surveys following the webinars that we've been doing. We really would appreciate your feedback about what's helpful, what's informative, what we could do better. So if y'all have a chance to stay on and click on that link right there in the public chat box and take our survey, I don't think it'll take more than a couple of minutes. We would really appreciate it a lot. And I guess I want to thank all of our presenters today again for sharing your experiences, your information, your recommendations, and thank you. And everybody, I think it's about time to bring it to a close. But thank you all for participating.